So, Dr. Scholz, we know that Gleason score is a vast topic, and when it comes to Gleason 7, I've seen a lot of questions coming up about what is Gleason 7, what does it mean? Can you explain what Gleason 7 is and how it's broken down?
It's referring to the grade, and we know that prostate cancer comes in many different genetic variations, and when you look at genetic variations of humans, some are tall, some are short, some have dark skin, some have light skin, and that's because the underlying genetics are different. And the tumor cells also have varied genetics, and some behave more aggressively, some behave less aggressively. And that shows up in the appearance of the cells under the microscope. And there are basically three categories that the professional doctors, the pathologists, assign when they look at these cells. They're category 3, 4, and 5. And 1 and 2 went away many years ago. 3, 4, and 5 are very distinct, different types of genetic prostate cancer, but sometimes there is more than one type in one patient. So you could have 3 and 4, or 4 and 3. And so the convention is to report both the types if two types are seen, and then to put the more common type, the more prolific type that was seen under the microscope as the number in first place, and then the second number, the less common type, in the second place. And so you have something like a 3 plus 4 or a 4 plus 3.
So this is actually the type of cancer that's within the prostate.
Precisely, yeah. So this is removed with a needle biopsy and then sent off for preparation and looked at by doctors who were trained only to look at stuff under microscopes. They're called pathologists.
So once the pathologist is done, he sends the report back to the urologist, and the patient gets that report back, has a discussion with the urologist. Do you think that urologists are explaining all the nuances of Gleason to the patient? Usually I don't see that happening. I think that patients kind of get this report and then they kind of come to us to have it explained. What would you want a patient to know when they get back maybe a 3 plus 4 or 4 plus 3 on a report? What are the nuances that they should pay attention to?
Well, it's a complex field. I think the overriding issue with prostate cancer is to first realize that it's different from all the other cancers. It doesn't matter if it's a 3 plus 4 or 4 plus 3, the chances of actually dying from it is very, very small. So for the most part, we're looking at how can we get by with the least amount of treatment so that we don't cause long-term problems with urinary function and sexual function and still cure the condition. So the refinements of 3 plus 4 versus 4 plus 3 then impact how much and what kind of treatment you use. Because if 4 plus 3, the 4 being a higher grade, being a type of prostate cancer that has a somewhat greater propensity for spreading, is going to require more thorough treatment to make sure you get it, whereas the 3 plus 4 is 3 being a lower grade, less of a concern, and can be treated with less aggressive treatment.
Does it matter where these different tumors are in the prostate, or is the grade just the most important part when it comes to deciding treatment?
Multiple things matter. Like if you look at basketball players, how well they shoot, how well they jump, how quick they run, how smart they are, do they pass well. All of these things are components of a good basketball player. I don't know what the number one thing is in a basketball player, but in prostate cancer, the number one thing is the grade, because we're always most concerned about the possibility of spread. But other factors like how big is the tumor, is it coming out the edge of the gland or in the seminal vesicles, those are important too. Just like there are multiple factors in a good basketball player, there are multiple factors in determining how risky a specific cancer is.
So do you use imaging to determine those factors?
Yes, modern imaging has revolutionized prostate cancer now. Multiparametric MRIs, we use color Doppler ultrasounds, enable us for the most part to see where the tumor is, how big it is, and also determine if there's more than one tumor, is it coming outside the edge of the gland. All those factors, as one would imagine, are very important in assessing how risky it is.
So when it comes to the size of the tumors, how much does that matter in regards to deciding on a type of treatment?
So the size is relevant. How extensive it is throughout the gland is somewhat related to the size. If you take a really big prostate where a larger tumor isn't like taking over the whole gland. A bigger tumor versus a smaller tumor is not going to have that much importance. The grade of the tumor will be a far more important outcome determinant than the size is. But it certainly is important if someone has a smaller prostate and the tumor is large. Obviously, focal treatment's not going to be much of a possibility for those individuals. There's a possibility with larger tumors that a random biopsy isn't necessarily representative, because you've got a lot of cancer, but you only take a couple biopsies. Each core is only 1 millimeter across, so are you missing higher grade disease? So a larger tumor does raise some questions about the possibility of higher grade disease lurking in a corner, but it hasn't proven to be as an important predictor as other things like the Gleason score itself. And so some men with Gleason 6 tumors that are large just have their disease sit there year after year. It doesn't cause any harm. So just being large alone is not necessarily really a serious problem, but it does raise some questions about could there be some higher grade disease that was missed, because biopsies are only taking a sample, and maybe some section of the tumor is harboring a little higher grade disease that's been missed. And that, of course, is why people need to be watched closely when they're on active surveillance. But it hasn't proven to be as big an issue as one might think.
How do you know whether the size of the tumor? How do you know if it's big or small?
Well, the most indirect way, of course, is if the PSA is high. Sometimes people think that may equate with a bigger tumor. Doctors can do a digital rectal finger exam, and sometimes they can feel a nodule, and if that's the case, they can judge how large it is. But more commonly, when men are undergoing random biopsies, when they do these grid patterns, you can see how if 1 or 2 cores have cancer in them versus 8 cores, that's going to equate with a larger tumor. And now, of course, with these MRI scans, color Dopplers, PSMA PET scans, the scans literally can show how large the cancer is on the scan itself.
Thanks for watching. If you would like more information about the topics we discussed today, you can go ahead and visit our website at PCRI.org. Don't forget to subscribe to our YouTube channel. We come out with new videos every single week.